Chemistry from Anderson University. She has been administering vaccines to sexual populations for 3 years and has a special interest in women's health. Emily recently completed an exclusive 6-week intensive working directly with Drs. Hale and Crutch, authors of Medication and Mother's Milk, and is expected to graduate with her Doctor of Pharmacy degree in May of 2023 from Texas Tech University Health Science Center in Amarillo, Texas. While she finishes her last degree, Emily has stayed on to work with Drs. Hale and Crutch at the Infant Risk Center. So welcome, Emily.
And just a reminder, just so everybody knows, we're recording this part of the presentation. Okay, welcome, Emily. Let's see if we can get your picture to come out a little bit bigger here. Let me redo the view. Oop, I can't figure it out, guys. Okay. Emily, I don't think we're hearing you. Are you talking?
No, ma'am. Can you see my slides okay?
We can see them. I'm going to blow them up. I just have to organize the screen a little bit better. So
Okay.
Give me 1 second and make it so that I can make it a little bit bigger. Yeah.
I think she said she was thin.
Oh, okay. But I think I have to full screen this. I think we're good now.
Okay.
Yeah. Okay. All right. Okay. All right, Emily, are you, we're ready when you are.
Wonderful. Well, thank you so much for that introduction and for having me today. South Carolina definitely has a special place in my heart, and being a part of the Infant Risk Center was a great opportunity for those two things to come together. So I'm excited to present to y'all today on vaccine hesitancy, the safety of influenza and COVID-19 vaccines during pregnancy and lactation. There are no financial conflicts of interest. Let's see. Well, previously these were going to pop up so that y'all couldn't see the answers, but here is a little myth or fact. The flu shot can give you the flu, and the COVID-19 shot can give you COVID-19. This is a myth. Neither of the inactivated flu vaccines nor the COVID-19 vaccines contain the live virus, and so they cannot cause infection. Myth or fact, getting vaccinated means risking long-term health and fertility. This is also a myth. There's no evidence that vaccine ingredients cause any problems with future health or pregnancies. And finally, myth or fact, if you have already had COVID-19, you do not need to get vaccinated. Myth, this vaccine is still highly recommended. The duration of natural immunity is unknown and results in fewer detectable antibodies compared to the COVID-19 vaccine. Here are the learning objectives that we will be covering in this presentation. First, recalling the current recommendations for influenza and COVID-19 vaccines in pregnancy and lactation. Second, compare and contrast the mechanisms of the influenza and COVID-19 vaccines. Reviewing the poor outcomes associated with influenza and COVID-19 infections. And finally, discussing pertinent literature findings related to the safety and efficacy of influenza and COVID-19 vaccines during pregnancy and lactation. So let's begin with current recommendations in pregnancy and lactation. Here on the far left side of the table, you will see common vaccines that are recommended for adults in the United States. In the middle column, you can see that the vaccines are classified as either safe or not recommended in pregnancy. However, in the far right column, for lactation, the majority of the vaccines are safe while breastfeeding, except for the yellow fever vaccine, which is only recommended in high-risk breastfeeding mothers. So what about influenza? The Centers for Disease Control, or CDC, recommends that pregnant women should get a flu shot, however, not the live attenuated vaccine. Additionally, postpartum women, even if they are breastfeeding, can receive either type of vaccine. The Society for Maternal Fetal Medicine, or SMFM, released a statement in 2019 that the flu shot is safe during pregnancy, and pregnant women should get the flu shot as soon as possible after it's available. And the antibodies that are created from maternal vaccination may protect babies up until they can get vaccinated at 6 months of age. The American College of Obstetricians and Gynecologists, or ACOG, recommends that pregnant women and women who are breastfeeding get the flu vaccine each year, even stating in April 2018 that maternal influenza immunization is an essential component of prenatal care for women and their newborns. So let's look now at COVID-19 vaccine recommendations. The CDC in 2021 recommended and encouraged all pregnant people or people who are thinking about becoming pregnant, as well as those who are breastfeeding, get vaccinated to protect themselves from COVID-19. Just this month, they released an additional statement that COVID-19 vaccination is recommended for all people aged 6 months and older, including those who are pregnant, breastfeeding, trying to get pregnant, or may become pregnant in the future. The SMFM was one of the first organizations to strongly recommend that pregnant and lactating women have access to COVID-19 vaccines. And just last month, they endorsed the current CDC recommendations with particular emphasis that all pregnant, recently pregnant, or lactating people receive a bivalent booster to mitigate risk. Also last month, ACOG released a statement that recommended all eligible persons aged 6 months and older receive a COVID-19 vaccine or vaccine series in line with the CDC recommendation. And the Academy of Breastfeeding Medicine, or ABM, said in 2020 that they did not recommend cessation of breastfeeding for individuals who are vaccinated against COVID-19. However, currently, they do not have a statement on their website and instead encourage patients to consult resources such as the CDC and World Health Organization for the most recent guidance. In summary, the CDC, SMFM, ACOG, and ABM recommend annual influenza vaccines during pregnancy and lactation. For influenza vaccines, the inactivated vaccine is preferred, and live attenuated vaccines should be avoided. The vaccine is recommended early in the flu season as soon as the vaccine is available. These organizations also recommend a COVID-19 vaccine series while pregnant or breastfeeding. Vaccination may occur in any trimester, and mRNA vaccines are preferred, including the new bivalent booster. So now that we've reviewed published recommendations for influenza and COVID-19 vaccines, let's analyze where those decisions came from. We're going to look at the data, but in order to understand it, let's briefly review how the influenza and COVID vaccines work. All vaccines have a similar mechanism of exposing the human body to an antigen, also known as a toxin or a foreign substance, in order to create a memory response. When you're looking over here at the left side of the diagram, you can see where the vaccine antigen enters the body, and then the dendritic cells, which are the first responders, will ingest the antigen, activating inflammatory cytokines and migrating to the lymph node. When the antigen is presented to B cells, they will bind and neutralize the viruses and the bacteria, allowing uptake by macrophages and neutrophils, which are just immune cells in your body. Alternatively, T cells will directly and indirectly kill the infected cells. All of these processes result in antigen-specific antibodies. While all vaccines have the same basic concept, they all work a little differently. So let's start with the flu vaccine. As I stated previously, the inactivated influenza vaccine is preferred in pregnancy and lactation. So you can see, starting on the left side, how the inactivated influenza vaccine is created. The viral strain is selected, the strain is inactivated using heat or chemicals, and then the vaccine is produced and injected. This results in an immune response and neutralizing antibodies in the body. However, there are 3 different types of coronavirus that I would like to address today. The first is protein-based. This protein subunit vaccine takes a small, harmless part of the virus and turns it into a vaccine in order to stimulate your immune system to create antibodies. If you later become infected with COVID-19, the antibodies will be there to fight the virus. One example of this vaccine is Novavax. Secondly is the viral vector vaccine. This takes a small part of the virus and then modifies it into a viral vector, which is then injected into the body in order to stimulate an immune response. In the same way as the protein-based vaccine, the antibodies will be there to provide protection if you are exposed to COVID-19 in the future. Finally, you have the mRNA vaccine, which is genetically engineered to give your cells instructions on how to make the spike protein, which is found on the surface of the coronavirus. After vaccination, the cells make the spike protein and display it on their cells so that the body creates antibodies. So if you later become infected, once again, you have protection against COVID-19. I would like to point out that after delivering the instructions to the cells, the mRNA is extremely unstable, and so it's immediately broken down. It never enters the nucleus of your cells where the DNA is kept. 2 examples of the mRNA vaccine that you may be familiar with are Pfizer and Moderna. As you know, infants rely on maternal antibodies for protection from infection. Both IgG and IgA are examples of antibodies that target the flu and coronavirus. IgG antibodies are the only type of antibody that can cross the placenta of a pregnant woman in order to protect the fetus. It provides long-term immunity by remaining in the baby's circulation for months and allows the infant to activate systemic immune response. Alternatively, IgA has a secretory component which allows it to transfer to the baby via breastfeeding, coating the mucous membranes of the gastrointestinal tract and neutralizing viruses for immune protection. It does not need to be absorbed in order to have a protective effect. Okay, so we've reviewed a little bit of the guideline recommendations and also how vaccines work. So now let's discuss poor outcomes associated with influenza and COVID-19 infection. Studies show that influenza infection in pregnancy results in increased illness severity and risk of death or negative outcomes. In fact, in the 2009 to 2010 flu season, among U.S. women aged 18 to 29, pregnancy accounted for up to 29% of influenza-associated hospitalizations and 16% of death. Additionally, findings have showed a 5-fold increase in perinatal mortality, including miscarriages, stillbirths, and early neonatal diseases and death. These poor outcomes may be exacerbated among chronic cardiac or pulmonary disease, diabetes, chronic renal disease, malignancy, and immunosuppression. Looking at the COVID-19 infection in pregnancy, pregnancy has been found to be an independent risk factor, demonstrating a 3-fold increased risk of ICU admission and a 1.7-fold increased risk of death. Potentially negative outcomes include placental histopathologic abnormalities, hypertensive pregnancy disorders, increased risk of preterm birth, cesarean delivery, and postpartum hemorrhage. These may be exacerbated among mothers over the age of 35 with a BMI over 35, diabetes, heart disorders, or Hispanic or Black disparities. Regarding COVID-19 infection in infants, there's an association of severe illness and hospitalization. In two studies published in March 2022, over 20% of pediatric hospitalizations for severe acute COVID-19 were infants, and 75% of infants with the severe disease were less than 6 months old. Additionally, 63% of hospitalized infants and children had no underlying medical conditions, and 44% of hospitalizations occurred in infants less than 6 months old, demonstrating a high risk in this population. Here you'll see a graph of the COVID-19 pediatric deaths from January 2020 to October 2022. As you can see from the bar graphs on the far left, 27% of pediatric COVID-19 related deaths occurred in infants aged 0 to 11 months of age. Okay, now to the good stuff. Let's dive into the data. Influenza vaccines in pregnant and breastfeeding women first. So influenza vaccine efficacy has been found to be protective against laboratory confirmed influenza, and the trivalent inactivated vaccine was up to 50% efficacious in pregnant women in a study published in 2020. Neither of these studies included quadrivalent influenza vaccines, and so protection is likely even greater now in a practical setting. For infants, the effectiveness of maternal influenza immunization on infants showed that infants born to unvaccinated mothers are 63% less likely to have influenza during age 0 to 6 months, which, as we discussed on previous slides, the less than 6 months mark is a high risk category. Additionally, a study published in 2014 found that infants of vaccinated women are 73 to 75% less likely to have low birth weight or preterm birth compared to those of unvaccinated moms. Some key takeaways from these studies are that influenza vaccines have extensive historical evidence for safe use in women while pregnant or breastfeeding. As I mentioned, live attenuated vaccines are contraindicated in pregnancy, but live attenuated or inactivated vaccines may be used while breastfeeding. Vaccination may occur in any trimester during pregnancy, but vaccination when first available is preferred. Finally, immunization decreases the risk of laboratory-confirmed influenza approximately 50% in pregnancy and reduces the likelihood of premature birth, infantile low birth weight, and infantile influenza infection by over 60%. Now let's look at the data of COVID-19 vaccines in pregnant and breastfeeding women. Pregnant and breastfeeding women are often excluded from clinical trials, and the early studies of the COVID-19 vaccine were no different. In December 2020, SMFM stated the existing practice of protection by exclusion is harmful and has been characterized as clinical experimentation on pregnant women, as vaccines are distributed and administered without the safeguards of research protocols in place. Only 2 weeks later, ABM stated we must protect pregnant and breastfeeding people through research, not from research. So with that being said, has there been enough research? Although COVID-19 has highlighted problems with FDA approvals for pregnant and breastfeeding women, there is now more research on COVID-19 vaccine safety in pregnant and breastfeeding women than 99% of other drugs. Looking at safety first, there was a study published in July 2022 that evaluated over 45,000 pregnant women ages 16 to 49 that received the mRNA COVID-19 vaccine. Acute adverse events that required medical attention occurred in less than 1% of study participants within 7 days post-vaccination. Additionally, no serious acute adverse events that were evaluated in this study occurred more frequently in vaccinated women compared to unvaccinated women within 21 days post-vaccination. This is a table and forest plot diagram taken directly from the study. As I mentioned, here in the far left column, you can see the adverse events that were evaluated within the first 7 days. So that includes fever, malaise, fatigue, and local allergic reactions. The middle 2 columns are the data that were collected based on the number of events per rate of 10,000. However, I would like to draw your attention to the far right column, which demonstrates the 95% confidence interval. The important part here is that if the horizontal lines that are displayed cross over the vertical line at 1, then that data is not considered statistically significant. So with these acute adverse effects that were observed during the first 7 days, none of those horizontal lines cross over 1, and so they would be considered statistically significant in this study. However, with the adverse events that were evaluated within the first 21 days post-vaccination, you can see that while the results are not statistically significant, they do show that there was not a dramatically higher risk with vaccination as opposed to lack of vaccination. Now that we've discussed safety, we can look at efficacy of the maternal vaccination and its impact on infants less than 6 months old. In another study published in July 2022, over 1,000 infants with a median age of 2 months were evaluated. The findings of this study include 52% overall risk reduction in infants. It was found that a 38% risk reduction existed if the moms were vaccinated before 20 weeks pregnant, and 69% risk reduction if the moms were vaccinated after 20 weeks of pregnancy. This study did evaluate the Delta variant and the Omicron variant, showing an 80% risk reduction with Delta and a 38% risk reduction with Omicron. Overall, there was also a 70% reduction for infant ICU admission. This is a graph from the previous study that I just mentioned, showing that infants born to unvaccinated mothers, as designated by the dark orange, are more likely to be admitted to the ICU, have a critical COVID-19 infection, require mechanical ventilation or non-invasive mechanical ventilation, or undergo vasoactive infusion compared to infants born to fully vaccinated mothers. Looking at the components of breast milk, I'd like to briefly review this study that was published in August 2021. It studied 7 participants in Portland, Oregon between December 2020 and January 2021. The findings were that there were significantly elevated levels of both IgG and IgA antibodies in human milk beginning only 1 week after the initial vaccine dose. This is an interesting finding because the general consensus among the breast milk community is that IgG is only transferred via the placenta and not the breast milk. And so I would like to see further studies and evaluation of how they determined the IgG concentration in the breast milk. But as you can see by their data on the right-hand side, you can see that pre-vaccine IgG and IgA levels were minimal, and they were dramatically increased after vaccination. Further discussing antibodies in breast milk, this study was published in November 2021 and also found significant transfer of IgA and IgG antibodies in breast milk. But this study did point out that IgG was not detected in the infant plasma levels when the mother was vaccinated during lactation. And the IgA levels were negatively associated with infant age. So as the infant got older, the IgA levels were lower. A common concern about the mRNA vaccine is if there's mRNA in the breast milk. I've included 2 studies here from October 2021 and November 2021 evaluating mRNA contents in human milk. The first study was mentioned previously with the study of 7 breastfeeding mothers. However, one of their additional findings was that there was no detection of vaccine-associated mRNA up to 48 hours post-vaccination. And the author mentioned that any mRNA that may have been below the detection limit would have been broken down by proteases in the gastrointestinal system, so infant exposure would be minimal. In the second study, there were also no findings of increased pegylated protein concentration, which here would be representative of the mRNA-based vaccine lipid nanoparticles, and this evaluation occurred up to 2 weeks post-vaccination. So some key takeaways regarding COVID vaccines in pregnancy and lactation are that vaccination during pregnancy and lactation provides antibody protection for both mothers and infants. COVID vaccines are likely safe in pregnant and lactating moms, but mRNA vaccines are preferred due to the risk of thrombocytopenia syndrome with the Johnson & Johnson vaccine. There has been no vaccine mRNA, which is what codes for the spike protein, found in breast milk post-vaccination. And vaccination may occur in any trimester during pregnancy, but as we discussed, vaccine receipt after 20 weeks gestation may result in greater antibody transfer to the fetus. However, vaccination before 20 weeks gestation may provide earlier maternal protection against COVID-19 infection. So it should definitely be a discussion of risk versus benefit with your doctor. For the last leg of this presentation, I would like to touch on some additional safety data related to the COVID-19 vaccine to provide you with enough knowledge and confidence to make your own vaccine decisions. So a lot of you may have heard of this before. When you get vaccinated, it should be offered to you. However, the CDC has come up with a program called Vaccine Adverse Event Reporting System. And one component of that is the vSafe COVID-19 Vaccine Pregnancy Registry. So it's a smartphone-based tool which uses text messaging in order to provide surveys and personalized health check-ins after you receive the COVID-19 vaccine. This system collected data from December 2020 to June 2021, bless you, and pregnant people reported as vaccinated counted to over 65,000. And there were almost 23,000 COVID-19 vaccine pregnancy registry enrollees. Here I've included some of the self-reported interview data that was collected by vSafe. As you can see, the pregnancy outcomes of live birth, miscarriage, stillbirth, and induced abortion are relatively consistent across the Pfizer, Moderna, and Johnson & Johnson vaccine. Now I would like to draw your attention to the bottom of the screen. The stillbirth rate per 1,000 live births recorded in the pregnancy registry was 2.45. Compared to the 2017 data, this is actually lower than what was reported that year at 5.89. So it is important to look at the percentages rather than the number of infants because each vaccine had dramatically different population sizes, but overall the outcomes were comparable and the stillbirth rate was not alarming. Some conclusions based on the vSafe data include no increased risk of spontaneous abortion, no increased risk of major birth defects, and no increased risk of pregnancy-associated outcomes. Now for our final conclusions regarding the influenza and COVID-19 vaccines during pregnancy and lactation. Benefits likely outweigh the risks in pregnant and lactating women receiving the influenza or COVID-19 vaccines. The influenza vaccine, inactivated vaccine, is preferred, and it may be received during any trimester of pregnancy or during lactation, but the vaccine is recommended as soon as it's available. The COVID-19 mRNA vaccine is preferred. No vaccine mRNA has been found in breast milk post-vaccination based on current available literature, and antibodies have been found in breast milk as early as 1 week post-vaccination. And these antibodies are very important for providing both maternal and infant protection. The COVID-19 vaccine may be received during any trimester of pregnancy or lactation. Here, I've provided some additional resources for any further questions or research that you may desire, including the CDC, ACIP, ACOG, ABM, AAP, and then the WIC for South Carolina, Mother to Baby, which is run by the Organization of Teratology Information Specialists, and then finally the Infant Risk Center call center and apps for additional information. So once again, I would like to thank y'all for having me today, and I will now take any questions that y'all may have.
Could you just let them know that the slides will be emailed to the council?
Yes. So the just to let everyone know, the slides will be emailed to everybody. Thank you for sharing your slides. We're also recording the video, and I just want to confirm with you that that would be okay, that if we posted that for just South on our site. Is that fine?
Yes, ma'am.
Can I post it as a YouTube? And usually we have it under a member, like you have to be a member to watch our videos, but this is such an important topic that we would like to just post it so that anybody who comes to our website has the opportunity to view it, if that would be okay.
Yes, that's fine.
Okay, thank you. All right. Questions? We've got questions on the floor.
Okay, yeah, if a pregnant mom goes to get a flu shot, how does she know she's gonna get the right one? Because you said there's 2 different types and she has to make sure she gets the right one. If she goes to say Walgreens or something like that, would she get the right one automatically?
Yes, that's a great question. So I have actually worked at CVS since 2017, and the inactivated vaccine is given 99.9% of the time. In order to not receive the inactivated vaccine, you would have to specifically request it, and even then it's not always in stock because it is given so infrequently. There's also the high dose vaccine, but that is only for patients 65 years and older. So I can say with confidence that if you were to walk into any pharmacy or public health center today, that you would be receiving the inactivated influenza vaccine.
Thank you.
Yeah, that's what I was going to say. So that, just so everyone can hear, Mimi, tell everybody that.
The live version of the flu shot is the nasal spray. If you have
Yes.
done that.
All right. Other questions? Rachel?
You were talking about the 20-week mark related to vaccinations prior to 20 weeks pregnancy rather than the 20-week after. Could you explain that just a little bit clearly about
Yes.
the advantage of vaccinating before or after?
Yes, absolutely. Give me one moment. Okay, so although I'm a pharmacy student, I have had some interesting insight into both the Infant Risk Center, and my mom is a midwife. So it was kind of fun to discuss some of these concepts with her. So in answer to the question about the efficacy of the influenza vaccine before and after the 20-week mark, my understanding is that before 20 weeks, it would provide the most benefit to the mom in order to get her that antibody protection as soon as possible. I can send out further information to y'all based on the levels of antibody titers over time. However, there is a component of anatomy when the fetus becomes fully dependent on the placental transmission around 20 weeks, and that's probably not the correct terminology. But the antibodies, the IgG antibodies specifically, have a higher level of transfer and development after 20 weeks, as shown by studies in infants. And once again, I don't have those numbers on hand. I thought that I might. But it has to do with the development of the baby over time and just a balance of risk versus benefit.
So you're saying more gets to the baby after the 20 weeks to carry them through that 6 months of life?
Yes, ma'am, that's my understanding.
Okay, thank you.
Because you have the full development of the placenta at that point. So the placenta is properly like implanted and, you know,
It starts actively
right,
transporting this
transporting,
IgGs.
yeah.
But if
Yeah.
you're, at first trimester in October, you should still get a flu shot, right? Could you hear that? I'm sorry.
The guideline recommendation is to get the flu shot as soon as possible, so late September, early October when it becomes available. And that definitely trumps the current data that shows it may provide further protection for the infant. This data is not selective to influenza vaccines either. There are other vaccines that have been studied that show, for instance, I think Tdap, based on the timing that pregnant mothers get that vaccine, that it's more beneficial in the 2nd to 3rd trimester for infant protection. However, based on the risk for pregnant moms with influenza, the guidelines still recommend that they get that vaccine as early as possible.
So with Tdap, I thought that that you want to do it somewhere around 36 weeks to maximize like the IgGs and how long it'll last, and also to make sure you get it in there before, if in case of preterm labor. Is that right or is that wrong?
What I reviewed, I didn't go into Tdap in depth, but what I reviewed was that it is recommended at least 2 weeks before delivery, like you said, so that the IgG antibodies are fully transferred to the baby, but that's why it's recommended so late in pregnancy at that 36-week mark rather than when you first become pregnant. So I would agree with your statement.
And it depends on who you try to protect, right? So with the Tdap, you're protecting the baby. With the flu, you're protecting the mom.
And
But
I think
you're protecting the baby, but you're also protecting the mom.
Yeah.
I think
Right.
Kelly also had a comment.
I was just going to say, I think ACIP recommends 27 to 36 weeks for Tdap, and
Mhm.
which I'm just happy you brought that up, because I was wondering, are there any contraindications that you see having COVID and or flu at the same time as Tdap?
No, I actually did review that in the guidelines. And you mean receiving the vaccines at the same time?
Yes.
From a safety standpoint, you could get all vaccines on the same day if you wanted to. However, from a practice pharmacy standpoint, we generally recommend that you give each vaccine 2 weeks apart in order to give your body enough time to heal, just so that you're not completely knocked out, exhausted, especially when your body is already working so hard to grow a baby. But per the guidelines, it would be safe to have to receive all 3 vaccines at the same time.
So what are the guidelines for if you're lactating? I mean, lactating is also very difficult on the body. Is that the same guideline?
Yes, and what I was saying about receiving all 3 vaccines at the same time, that's actually not specific to pregnancy or lactation. That's for all adults. And I can send you further.
You still should try to do 2 weeks apart for each vaccine. That's like last resort if you're never coming back to the doctors.
But a lot
But in
of
children,
people,
we give,
Yeah.
5 vaccines at the same time.
right, I was thinking that too, but also you gotta,
We can study that though, like there's no studies of all the vaccines being given at once.
Well, it's what is recommended. I'm assuming, I have not looked at the guidelines, but Emily, as a pharmacy student, have you seen any data about like the pediatric schedule and how we give, in babies, 5 vaccines at the same time? I'm a nurse practitioner and give it all the time, but I would just assumed that it had been researched as being safe and effective. But would that 2-week rule apply to infants and children as well, or?
Right, like I stated, the 2-week rule is really more of a accepted practice recommendation and not written in the guidelines. I became a certified immunizer in 2019, and we did look into the pediatric immunization schedule at that time, and the benefits of getting vaccinated with those all as based on the vaccine schedule outweighed the benefit of potentially giving the body time to recover between vaccines. But I have not looked at data regarding that since 2019.
we do have a pediatrician in the room if you'd like to address this.
Yes.
Yeah, I think that's hard
Okay.
because it does get a little off the script of kind of what we're here for. And I think,
Yeah.
you can find things to lead you any direction, but definitely, with specifically some of the bacterial protection that you need in the first couple of months of life, the benefit highly outweighs the risk.
Right, the consequences of it not getting vaccinated. And the other people, so many people have difficulties getting to all these appointments. You've got to chunk things together, transportation, time, so there's not just like, okay, optimal. We also have to do things that work for people, right? And the risk of not doing it to have optimal is you may not be optimal.
Yeah, I get it.
Right.
Thank you. That's great input.
And just a 2-second back on the timing of the before 20 weeks and the after, I think a lot of that for both of these vaccines, since they're not cellular long-term protection that it's giving you, it's just a brief antibody spike that will gradually decline for both COVID and flu by the 6 to 8 month mark. And so I think that's where a lot of that protection before 20 weeks is really mom's protection. Her protection will be waning towards the end of pregnancy anyway. So the baby's response is going to be low after birth just because mom's levels are low. Whereas an acute, sort of exposure to that stuff and high antibody levels in mom's system are going to equate to high levels of transfer to the baby. So, and I love those antibody breast milk studies. They're just so, again, why is this only COVID we've studied this for? But it's really, really cool to see just the high levels of antibody protection given to babies post mom's vaccination.
For such a short period of time. I didn't realize it was a week. That's really cool.
What to do it,
The antibodies are seen in mom's milk within a week of the mom's vaccination.
right? Yeah.
And great, high levels of antibody protection.
And the IgG too. And those, just to go back to that, when the moms, tell us when those mothers got vaccinated, at what stage in lactation were those studies done? Was it early lactation, late? I kind of missed it on the slide.
Oh, I don't know
for
if you
how
missed
many
it.
antibodies.
I may not have included it. Let's see.
It's kind of a mix because they just wanted as many people in.
Right,
so
but it-
comfortable zeroing in.
Right.
So it was a big age range of lactating.
Right, because you would expect more transfer of antibodies if it was done early, right? Especially in maybe the first week after birth versus later, because your cells are, your tight junctions between your cells aren't closed. So,
Yes, great point. The studies that I had reviewed in the presentation like previously stated, were within 7 days post-vaccination and then within 21 days post-vaccination. But I am not sure exactly like the timeline related to when the mothers gave birth.
Right, how far postpartum? Yeah, yeah. Anybody got any other questions? I have like 5 million questions, but should I ask another one then? Anybody online? Well, have somebody online go.
We have time. We're good, time wise.
Okay, I had a question. Oh, sorry, Kelly, go ahead.
But I was just looking, the antibodies in the breast milk, right? You're saying that you have an increase of IgA being transferred, right? I got that right?
Yes, ma'am.
Is
IgG.
there any correlation between the antibodies, this vaccination, these are vaccines given during breastfeeding, but not given before birth, right?
Correct.
Given after birth while breastfeeding.
Yes.
Did they look at any increase in IgG and IgA given during the pregnancy, but not during breastfeeding? Like for mothers and infants after delivery, but that were not breastfeeding? Because is there any correlation with the actual breast milk also, like in conjunction with the vaccine, increasing the IgA?
That's an excellent question. I think it goes back to, I'm sorry, I don't know your names, but someone who spoke in the room earlier made a really great point about the 20-week mark, and about how IgA is, it decreases as the baby's age increases. So there's definitely potential for IgA to be conveyed or transferred through the breast milk if the mom is vaccinated toward the end of her pregnancy. However, it's just purely based on the timing in order to maximize that 6 months of protection. I think also the point you're making is a great one, because I mentioned that a couple of the studies were finding increased levels of IgG in breast milk. And Dr. Hale sent me an article this morning that was saying it has been generally accepted for the past years that IgG is not transferred in breast milk. It's only transferred via the placenta to the fetus. And so I'm definitely interested in further research about getting vaccinated during pregnancy versus during lactation. And additionally, some studies hinted at the idea of getting a vaccine during pregnancy and then receiving a booster after delivery. So I'll be interested to see what additional literature comes out over the next year or so.
Thank you.
Great question. And Dr. Crutch and Dr. Hale are definitely our experts. So I'm just here doing the best I can today.
You're doing a great job. You're doing a great job. This is great. We get to put you in the hot seat because you're here, but you're doing a great job. So, and it's so interesting because animals, like typically pass IgGs through their colostrum. I don't know if you did that.
I did not know that.
Yeah, so like they don't pass IgGs through the placenta, like a cow will not pass IgGs through the placenta. And so if that cow does not get colostrum, they're gone, right? So it makes some sense that there is some IgGs in human milk before the cells are really bound closely together. And aren't there some?
There are some, but the two studies that I looked at, it was a very high level of IgG. And we've always known that, like you said, there was some leakage between cells. But But with these two studies that were done in July of this year, they found very high levels. So like I said, I'll have to look into that a little more.
So this is my devil's advocacy here. Advocate, that's not advocacy. I don't think. You don't want to, yeah. Anyway, I'm going to be, so I feel like some lactation consultants have noted mastitis after vaccination.
Okay.
And in the breast that's close to the arm. Has anybody else seen that?
There was a lot of
Inflammation,
lymphatic,
yeah.
like,
Right.
lymph nodes, lymphatic.
So here's my devil's advocate. If we're getting inflammation near the breast, are we opening tight junctions and letting IgGs through?
That's a great hypothesis.
Yeah, probably. I mean, I just got my booster and I had armpit swelling even though
Right.
I'm not
So
lactating.
I've definitely seen that in the clinic that people are gonna have that, but you know, is it incidental? It's just an observation. But wouldn't that, and like, if that's the case, have we looked at milk from one breast or both breasts? Which breast is it coming from? Have we looked at inflammation? Like, you know, like,
It has a role, it has a purpose. Nature's making it happen.
right. So then are we, is that why we're seeing that with this COVID vaccine? Because we have this inflammation. Do you know of any studies, which you may not, and I know we're totally putting you in the hot seat, but I want to know if there's studies, and I haven't looked, on mastitis, or if there's case reports on mastitis after COVID vaccine.
I
Or
saw
any
a lot
vaccine.
of studies, but that was actually one that I did not come across at all. So that is a really interesting thought. I was excited about the amount of breast milk studies that are out there. It really surpassed my expectations, but I actually did not see anything specifically focused on mastitis.
And I feel like lactation consultants don't do a lot of case reports.
And how are we talking about mastitis? Are you talking about with the true mastitis spectrum where it's not actually infectious mastitis, it's inflammatory?
Right, inflammatory
A lot
mastitis.
of people use the word.
Right. Well,
Infection
unless,
not be inflammatory.
but there's no, so you can't tell. I mean, people come in, they have mastitis, you're giving them an antibiotic. Is the antibiotic working, or is it just going away because the inflammation is going down? Right? Like, there's no counterfactual, right?
Probably
So,
not recommending antibiotics right away.
yeah, well, I mean, within 24 hours, it's still on the ABM protocol. That new ABM protocol that came out. So, so I don't know. Yeah, I mean, that's what I've been wondering. I don't have time to do that. So, anyhow, but yeah, that's what I was wondering because I had read that before, and that's been in my head, and then I've been wondering if there's case reports about mastitis, and if there's not, then we need to figure out whether it's happening or not.
Yes, I just scribbled that down. I think that's a really great point of discussion. And I really think it's unique perspective provided from y'all as lactation consultants, because that's personally something that would not have occurred to me as a pharmacy student. So that's excellent.
Anybody else? Questions? Let's see. I was going to bring up the one more point that, we think about preserving breastfeeding and flu and COVID vaccines. And one thing that I don't think that is spoken about a lot is that, babies obviously we know that they don't get hospitalized as much when they have respiratory, if they're breastfeeding, they don't get hospitalized so much with respiratory or gastrointestinal infection. Your data shows that what you're presenting shows that they're not going to get hospitalized as much if they have flu and COVID vaccines. But the other thing we don't talk about is the actual effects of hospitalization on breastfeeding, right? And we know those babies come to the hospital and they're on oxygen, and now mom's got a pump because
That's
baby's
an
not taking
excellent point.
milk of the breast. So we need to wrap this back into breastfeeding. Like, okay, this is going to protect your child in these ways, but it also protects the breastfeeding relationship, right?
Yeah,
So
that's an
there's
excellent point.
secondary effects of breastfeeding. So, anyhow, I think we need to add that like little argument to our arsenal of trying to help people, get healthy. So, all right, anybody else? Could I ask for one more thing? I'm sorry. That forest plot. Can you put that forest plot back up?
Let's see.
I felt like I didn't get a really good look at it.
Yes, no problem.
Okay. So the first part of that, when you have the 4 studies on the top, yeah, if you increase the size of that,
Possibly. Oh, I can on my other screen. Let me do that instead. Oops.
okay. And I just, if everybody wouldn't mind, if you could just tell us how the first 4 or 5 studies differ from the second, because I think I missed that.
Okay. Okay, is that what you were talking about?
Yeah, okay. So that's 1 to 7 days after vaccination. And there's a little bit higher risk of acute adverse effects. Okay. But when you look at 1 to 21 days, most of those studies showed that the confidence intervals were all over the place. So the risk was just very variable.
Yes.
Yep. Okay.
Yes. And my conclusion was that since the confidence intervals crossed 1 over the majority of the post 21 days acute adverse effects, that they were still valuable information, but not statistically significant.
And look at that. Look at the, I can't say that word.
Lymphadenopathy, or yeah.
Yeah. Look at that. And that's the only one that crossed, right? How about that? And the risk ratio is what? 2 points. So 2 times the risk of that. That's interesting. And look, inflammation, signs of inflammation for 1 through 7, fever, malaise, all of those mastitis-y, ooh, I feel really crappy symptoms. So that's interesting. So all those awful things like the PE, we don't want a pulmonary embolism, or all the thrombosis, that type of thing. That's not really increased because a lot of those are mostly blood issues, right? Thrombosis, coagulation, infarction. Most of those have to do with blood moving, clotting. But the other ones are the lymphedema is what I think of there, and the others are more like that, just inflammatory process.
Is this looking at every single vaccine, like the Moderna's or Johnson, all of these, or is this talking on one vaccine specifically?
Let's see. This was only mRNA vaccines, so it was both Pfizer and Moderna.
But that's fine. It's all what you're saying.
Yeah. Yeah, very scary.
Well, that's pretty interesting. All right. I don't have any, well, I probably could have more questions, but I'm going to quit asking questions. All right.
Well, you have my email.
Okay.
And know where to find me. So let's see. I think I can put it in the chat here too.
Thank you so much, Emily. That was fantastic. That was really great. Let's give you a round of applause.
Oh, thank you. Thank you so much for having me. It was so fun. So,
Thank you.
all right.
Have you
Well, I
paused
did-
your record?
I'm going to pause the recording right now, and then I'm going to restart it. Emily, you're welcome to stick around. We're going to have, tell me what's happening.
Benji's gonna tell us about her, feature seed,
Okay.
and then you are going to do the summary of the talks.
Okay, that's what I thought was happening. I was just making sure. Okay, all right. But you're welcome to stick around. Don't feel obligated. It's up to what you want to do. Okay?
Okay. I'll be here for a little bit and then I have class this afternoon. But thank y'all again so much.
All right, thank you.
Thank you, Emily.
All right, I'm gonna, give me a second. Okay, stop recording.